If you want to draw the portrait of the classical patient that we have to see in consultation for myelodysplastic syndrome, it's mostly someone between 17 and 80s. Most of the patients are coming because of anemia-related symptoms. Anemia is the diagnosis symptom in 70% of the case, 60 to 70% of the case. So it's really, in that case, what's driving the patient to go to clinic and to have some more tests done. Anemia is a common feature in elderly patients. Myelodysplastic syndromes is less frequent than other causes of anemia, but we see more and more patients with diagnosis of myelodysplastic syndromes. When we talk about the population of myelodysplastic syndromes, basically there's some common features between low risk and high risk disease, but also some big difference. The main characteristic that we need to keep in our mind when we talk about myelodysplastic syndrome, it's mostly a situation that we have to face for elderly patients. Median age is 75 years. There's a group of patients which are therapy-related myeloid neoplasm. It's a little bit on the side of that. It's mostly younger patient that has been exposed to genetic insults such as chemotherapy, radiation therapy, but it's on the side as compared to the most common and general population of de novo myelodysplastic syndromes, where we have this elderly population. And as I mentioned, we basically have two big groups of patients. The lower risk population, which represents something like 70 to 75% of the new diagnosis of myelodysplastic syndromes in the high risk patient, or 20 to 25% of the patient. Low risk patient, in this case, we need to consider myelodysplastic syndromes as a chronic disease, like we need to consider diabetes or hypertension. And it will be a chronically ill patient, where the main issue will be to deal with the cytopenias. And in that case, the patient, through times, usually have increased needs for transfusion, mostly anemia and red blood cell transfusion. And that's what drives the prognosis. Dealing with the cytopenias and their consequences, including iron overload, for example, are the main drivers of prognosis for these low risk patients. Transformation and evolution to leukemia, in that case, is less frequent. That's what we call lower risk, in fact. And it's not driving the prognosis. Most of the patients, in that case, will have some issue and potentially at the end die because of the consequences of the transfusions and the cytopenias. When we talk after that about the high-risk population, situation is completely different. These patients more or less behave like acute myeloid leukemias. They have cytopenias, but the evolution of the disease is really driven by the proliferation of cells in that case, and by the potential evolution to acute myeloid leukemia. So the type of approach that we have to deal with is completely different as compared to the lower risk patient, where we can expect a median overall survival of 8 years, 9 years, 10 years, while in myelodysplastic syndromes with higher risk features, we can only expect, without treatment, median survival of 1 or 2 years in some cases.